Good morning, everyone, or good afternoon. I am R Hamdy. I'm a pediatric orthopedic surgeon at the Shriners in Montreal, and I'm very happy to be here. I would like to thank also Professor Hemant Sharma for asking me to present this, and I hope you will enjoy it. So today we are going to talk about the knee height asymmetry and does it matter? I have nothing to declare. The objective of this talk first will go through the definition of knee height asymmetry, how to measure this asymmetry, what are the effects of knee height asymmetry, what we know, and more importantly, what we don't know. And at the end of this presentation, trying to convince you that really knee height asymmetry does matter. So what is knee height asymmetry? It's the difference in the level of both knees, standing, sitting, or supine position, when the pelvis is level, and that's the most important thing. Or the whole lower limb standing EP if you are taking X-rays with or without LLD. So on the left here you can see a X-ray of the whole lower limb standing EP. There is an obvious LLD. The pelvis, however, is level, as shown by the red arrow. Therefore, if you calculate the difference between A and B, this is a knee height asymmetry. And this example, there is an LLD and there is a knee height asymmetry. However, and we are going to see this in the next few slides also, you can have a knee height asymmetry without LLD. The example that you can see on the right-hand side, the pelvis is level, measurement of the whole lower limb, there is no LLD, but there is obviously a knee height asymmetry. So again, to repeat this, the first figure on the left, pelvis is level, the knees are level, therefore there is no knee height asymmetry. On the next one, pelvis is level, however, there is an obvious knee height asymmetry in that case. As you can see here and appreciate, the most important factor to have a knee height asymmetry is above the knee. So if the femurs are unequal, you will get a knee height asymmetry irrespective of what happens below the knee. In that case, it's not a true, it's an apparent knee height asymmetry. Why? Because we are starting with an oblique pelvis. The hips are not level, and if you can see here, there is a knee height asymmetry, which is the amount of B. However, A equals B. So if you make the pelvis level, the knee height asymmetry disappears. So that's an apparent knee height asymmetry. So why does it matter? Why we are talking about the knee height asymmetry? Well, the first thing, it's a largely unknown entity and a poorly understood deformity. Our standard deformity, when we do a deformity analysis, that includes the angular deformities in the coronal and sagittal plane, rotational deformity, translation deformity, LLD. But there is no mention of knee height asymmetry anywhere. We have an LLD clinic, but there is no knee height asymmetry clinic, and I'm not aware of any place, any hospital, where there is something called the knee height asymmetry. Usually the patients are followed for an LLD and not for a knee height asymmetry. And what complicates things is that knee height asymmetry and LLD usually coexist. However, you can have a knee height asymmetry as an isolated deformity without LLD, and that can be easily missed, as we are going to see in the next example. So it's if you review the literature, as I mentioned before, it's a very poorly documented deformity. Very little has been published. And the little that has been published and what we know about the knee height asymmetry is very concerning. However, what we do not know can be even more concerning. We don't know exactly the incidence. We don't know details of the knee joint loading. We don't know the long-term effects on the articular cartilage and development of OA. And more specifically, what is the acceptable amount of knee height asymmetry? If we look at all the main textbooks about deformity correction, and I've gone through them, and there is no chapter or no mention of knee height asymmetry as a separate entity. The second thing, apart that it's poorly documented, it can be very easily missed. And that's, we have a typical example. And I'll come back this in a few minutes to this example. 16-year-old patient, skeletally mature, there is a remote history of fulminant meningococcemia with multiple partial or total growth arrest. He was discharged from the clinic, from the LLD clinic, because it was reported and it was documented that he has no LLD and he had no pain. Therefore, he was discharged. He presented again at the age of 18 years with difficulty driving his car. And on closer examination, and if you look at the X-ray, you can see that yes, there is no LLD, the pelvis is level. However, there is a huge knee height asymmetry of about 6 centimeters. The left femur is shorter and the right tibia is shorter. So again, it can be easily missed if you are not aware of this thing. The next thing now that is really concerning about knee height asymmetry is that you can make it worse. Simply, it's by the treatment you are giving. So if you are looking at the first example, A, there is an LLD of 4 centimeter. It's a case of fibular hemimyelia, 2.5 difference in the tibia, 1.5 in the femur. You decide to correct the LLD and you do a lengthening of the femur equal to the total LLD. So you lengthen 4 centimeter. So you have corrected the LLD. Yes, the LLD now it's 0. However, you have increased the knee height asymmetry because you didn't take into consideration the ratio between the femur and the tibia. So that's, again, you can make it worse by your treatment. That's another example. In that case, if you look at the left tibia, there is a congenital pseudoarthrosis of the tibia with multiple surgery, and it healed finally. However, there is a residual total LLD of about 4 centimeters with the pelvic obliquity. And how to correct this? The parents and the patient refuse to have anything on the right side. You refuse to do anything on the left tibia, so you lengthen the femur to correct the LLD. Lengthening of 4 centimeters, you almost corrected the whole LLD. However, what happened is that you have a final knee height asymmetry of 4 centimeters. The incidence of knee height asymmetry, it's largely unknown. Very few articles in the literature. And we had one study here in our hospital where we looked at this consecutive series, 55 patients followed LLD, and we discovered that about 1/3 of them had a knee height asymmetry of more than 2 centimeters. What is concerning is that following successful surgery for the LLD, in more than half the cases, the knee height asymmetry increased, simply because we didn't really pay, any attention to the knee height asymmetry. How much knee height asymmetry is acceptable? Again, we do not have an answer to this. One of the very few articles that I found was by David Stanitsky in the Yellow Journal, and I quote what was written: a review of the literature indicates that there is no functional or cosmetic disability as a result of knee height disparities of less than 4 centimeters. However, that statement was based on what? We don't know. There are no references that was included, and you have no explanation how the authors reached that conclusion. However, we have here in a very interesting study by Weinberg and Raymond Lowe that was published in the JPO. He examined more than 1,000 cadavers from a huge collection, and he evaluated degenerative changes in the hip, knee, and spine. And essentially what he found is that if the normal ratio between tibia and femur, normally it's 0.8, if that changed, then it's a strong predictor of ipsilateral hip and knee osteoarthritis. That was studied, it was in cadavers, however, it was the first study that showed really that on the ipsilateral side, if the ratio, the normal ratio changes, then it predisposes to degenerative arthritis. The only paper really after this that we found regarding the impact and the clinical aspect, we reviewed 2 patients. It was not a paper, but it was an abstract that was presented, and we analyzed these 2 patients who had a corrected leg discrepancy and the knee height asymmetry. We examined the gait analysis, functional pain assessment using POTSI and the pain questionnaire, and also the cosmetic consideration. What was found is that several parameters of the kinematics and kinetics were changed in this patient. One of them was this one that I talked before, where there is a huge knee height asymmetry. Cosmesis, it's very important, and what many can do to hide this knee height asymmetry is simply by crossing the legs. In that way, we do not notice that there is a difference at the height of the knee. That is very interesting case, and I will finish on this one. I mentioned it at the beginning. 16-year-old fulminant meningococcemia who was discharged from LLD and later presented because of functional disability. It's a very interesting thing because he mentioned that he had problems driving. And when you examine closely, that's a view taken while he was sitting. One leg was shorter, the femur was shorter, and the other one was longer. So to use the pedals, he had problems, and he had to rotate his pelvis in order to be able to push his foot forwards. And that caused really problems driving. And you can see here what happened. And specifically, if we look at this video here, it causes problems squatting. If you notice here, he was squatting, but he's pushing his right leg, which has a knee height asymmetry relative to the other one, into external rotation. That's a very important functional limitation that he has. So that is X-rays. To treat this, how to address it, we had to lengthen the left femur, and we have to lengthen the right tibia in order to regain the knee height asymmetry. So the take-home message is knee height asymmetry does matter. We should be aware of the importance of the knee height asymmetry. The LLD and the knee height asymmetry can coexist, but knee height asymmetry can exist without LLD. And the knee height asymmetry, in fact, we believe that it should be incorporated in the deformity analysis as a fifth deformity, and it should be included in the surgical planning for LLD correction. And the aim should be aiming at a final lower limb segment ratio, tibia to femur equal to 80 over 100. Hopefully it was of some help, and I am ready to any questions. Thank you.